Welcome to our panel discussion on breast cancer care in India, innovations, accessibility, action, organized by Voice of Healthcare and supported by Alkem. Breast cancer is now one of the most common cancers affecting women in India. While there have been some advances in treatment and technology, not everyone can access these developments. Many women still face delays in diagnosis, lack of awareness, and limited care in rural areas. Today, we bring together doctors and change makers to talk about what's working, what needs to improve, and how we can make breast cancer care better and more available for all. Together, we aim to find real and lasting solutions. Our panelists for today's discussion are Dr. Sewanti Limaye, Director of Medical and Precision Oncology, Sir H.N. Reliance Foundation Hospital. So, Dr. Sewanti, welcome. Okay, I can't hear you, ma'am. I'll get back to you. Dr. Shyam Agarwal, Chairperson, Medical Oncology, Sir Ganga Hospital and Research Center. Welcome, Dr. Shyam.
Hello, good evening, everyone.
Dr. Urvashi Prasad, former Director, NITI Aayog. Welcome, Dr. Urvashi.
Good evening. Thank you.
Vicky Nanda, Chief Operating Officer, Niramai Health Analytics.
Thank
Welcome,
you.
Dr.
Thank you,
Mr.
Dr.
Vicky.
Manisha. Pleasure meeting all of you.
So, to begin with, my first question goes to Dr. Sham. How would you describe the current landscape of breast cancer screening in India, particularly in terms of early detection and referral pathways?
So, I think, as you rightly said, breast cancer has become number one cancer in our country, and currently, nearly 2 lakh new cases of breast cancer are diagnosed each year. And there is a huge issue in terms of early screening for breast cancer in our country. The first thing is to understand the significance of breast screening. That randomized studies and trials have shown 30% reduction in mortality if you diagnose breast cancer early, and even up to 50% reduction in mortality has been seen. So this establishes the efficacy of breast cancer screening to diagnose and pick up breast cancer cases early. Uh, but the problem is the availability of tools and equipment and the ability to reach into tier two, tier three cities, and even in the villages rural areas where most of the India resides. So, as a result of this inaccessibility to common people, and of course, there are other factors such as literacy and economic reasons and the lack of infrastructure for the availability of equipment like mammograms. So, as a result of this, we are not able to diagnose early breast cancer in majority of the patients who come to our clinic. So 60 to 70% of the times, patients with breast cancer are diagnosed in advanced stages, and we are only able to pick up early breast cancer, uh, in 30% or so. And I think suffice it to say that if you diagnose breast cancer early, the cure rates exceed 85 to 90% with the multimodal treatment as we have available today. So I think there are a lot of gaps in the understanding of people all across the country. People would include normal women, their willingness to go to a clinic or to a mammography machine every year or once in 2 years after the age of 40 years, which is the guideline for women over the age of 40 years. And of course, uh, the will of the government, that is the political will to provide infrastructure in the form of mammography machines at the district level or even beyond, but at least at the district level, since we have around 500 districts in our country. Then of course you do have hospitals, institutions, nursing homes, and NGOs who can contribute to this, willingness to conduct the screening tests for women, beyond the age of 40 years. And for women who are at high risk, the screening has to begin early, especially who have a high, history of family, breast cancer or ovarian cancer, or who have some genetic aberrations like BRCA1, BRCA2, and other germline abnormalities, which could predispose them to developing breast cancer. So I think a lot needs to be done. So just to say that in the US and in the Western world, 80% of the breast cancers are diagnosed in early stages. So which is in sharp contrast to the figures which we have from our country. So there is a huge unmet need here to convince women, society, NGOs, institutions, and politicians to see to this that the technology is made available and women are encouraged to participate in early detection. Besides mammography, just a couple more lines I'll say. The other two tools which are so readily available to women are breast self examination and clinical examination of the breast by a doctor or a gynecologist or a surgeon. So I think women also should be taught breast self-examination every month after the age of, say, 35 to 40 years, 3 to 5 days after their menstrual cycle. And I think that technique also needs to be spread so that any change in the shape of the breast or lump or change in the nipple retraction or any discharge from the nipple. So I think these are all warning signals which women should be taught. So I think a lot of education awareness needs to be spread as well. So I'll stop here and then maybe take this further.
Rightly said, sir. There is, disparity as far as the early detection of breast cancer is concerned when we compare the West with India, and especially with the availability of mammograms and other tools to detect the breast cancer early. I think it should be made accessible because early detection means more cure rate. Right, sir. So my next question goes to Ms. Urvashi. From a public policy perspective, what are the key systemic challenges hindering widespread breast cancer screening in India, especially in rural and low-income populations?
Thank you. So I would say that, at least when it comes to breast cancer, um, we have some sort of, even within the government, if I can say, some basic awareness of the need, for this kind of cancer. I think for a lot of other cancers, we're not even at this level, right? Lung cancer is an example, where we have absolutely nothing in terms of systematic, screening, because we've always regarded it as a smoker's disease. But now more and more, non-smokers are getting it thanks to our air pollution and various factors. So I think breast is still, in that respect, still far ahead of the curve. And yet, as we can see, that even in breast cancer, there are still huge gaps. Now, in terms of the screening, obviously there's demand and supply side issues both. So demand, we already heard, in terms of awareness of the general population, and that awareness actually translating into behavior change. Because it's one thing for me to be aware, but does it mean that I actually act on that awareness and I actually do my screening diligently, or even a self breast exam, do I do it diligently? So there's often a huge gap between just being aware and actually actioning that. So behavior change is a big problem, obviously, on the demand side. On the supply side, in theory, we should have breast cancer screening fairly widely available, because even the health and wellness centers, or the Ayushman Arogya Mandirs, as they are now called, which have been set up by the government, are supposed to provide screening for breast cancer, oral cancer, and cervical cancer. But again, as we know, health is predominantly a state subject. Implementation comes down to the state level. So there's wide variations in whether this screening is even happening systematically. And then, as we know, it's not just about the screening. What happens after the screening? If you have found some ladies to have some suspicions, do you really manage to refer them to the next level of care? Is that systematically happening? Is that systematically tracked? In most places, I would imagine not. So I think that is really our challenge on the supply side, that even though it is very much part of our guidelines, very much part of our schemes and programs in the government, the implementation, the monitoring, and of course, how can we use tech, to make all of this better, to make all of this effective, easier on our health workers, because the people you have at these primary health centers are not necessarily doctors, and that is fine. We don't even need doctors everywhere. We can't have them everywhere. But at least if they can be educated to a certain level, trained to a certain level, to do that basic training, or at least have a basic awareness of what are the kind of symptoms that somebody might present with, then at least they can do referral to somebody who's a specialist. So I think that itself is a big challenge for us, and that's what we need to really focus on, the public health sector side. I think clearly screening, early detection, these are all very much within the domain of the public health sector. So I think, of course, it's a political issue, as it was said. Ultimately, public health is political. And so the will is very, very important. And I think that's why we, in order to make our schemes, our programs more effective, we need to really convince those decision makers to say that it's not just about the lives, that go. It's not just the statistics. It's about all the people who are suffering when they could actually be, pretty much cured, because we now do have very good treatments, especially in breast cancer. So we could have all these, women who could be productive, who could be healthy. We could have families that could be healthy and contributing and happy, instead of, being in debt because they've come at stage 3 or stage 4, when treatments are more expensive. So I think we need to make a political case as well for this, because I think those in the public health space, like me, we're always convinced, and we don't need convincing. But it's the non, health folks who are often the decision makers, and they are the ones who really need convincing. So I think we need to make that case and continue to make that case more effectively.
Rightly said. So it is the public health centers where we require the awareness the most. Even if the doctor is not sitting there, technology can help, and even slightly knowing the symptoms can help, and refer the patient to the higher center. Dr. Sewanti, can you hear me?
I can finally hear you. I don't know how long my connection will stay, but happy to chime in.
All right. So, my question to you is, given your work in precision oncology, how do you see current screening practices aligning with personalized care model in India? Is India ready to integrate these precision tools at screening level?
So I don't know if you can hear me, but if you can, my only message on this forum would be to personalize screening. And that these are the lenses with which I've always looked at oncology. When we talk about generalizing anything, it becomes very difficult to deliver. So today, for those who have high risk of breast and ovarian cancer, today all of us who have family history, who have exposure, who have other reasons. Some people already are aware that they are BRCA carriers. Anyone who is in that bracket who can identify themselves as high risk must not forego screening. At least those who have cancers in their families must undergo age appropriate screening, including breast cancer screening. So, at least high risk identification should be the default. If not screening the community, at least we should be high risk screening. That's my way of pitching in the personalization of screening effort as well. We as a society, we as a nation do not screen. That's really sad. And those practices need to change. But at least those who are high risk must align themselves with yearly screening efforts, including breast cancer screening. Those are my 2 cents. Thank you.
Right. So if there is a family history, definitely the screening frequency should increase, and we can definitely personalize it, with the help of family history and genetic testing. My next question goes to Mr. Vicky. From your perspective in health tech innovation, how has the overall screening ecosystem evolved in recent years? And what gaps still remain when it comes to the adoption and scale of diagnostic technology across India?
Right. Thank you, Dr. Manisha, for the question. Um, what I feel is that definitely there is an evolution in the screening system and also in the methodologies. We saw the era of COVID specifically, because of that, we saw a lot of integration of telemedicine, right? And we also saw digital interventions. So that is one way if you look at from the evolution standpoint of view. But given that that we have ABDM today, we also have access to digital health IDs, digital health records. So that is also interesting part of this evolution. Uh, the objective is to increase the screening base through these interventions, whether we talk about interesting point of care technologies, which also become part of this ecosystem in this evolution. Because these point of care testing diagnostics will again increase the access. We saw during COVID times, we also seeing this, whether we are doing ECGs, whether we are doing, TB or other testing. But the interesting part is the intervention of AI and ML technologies, because those are actually giving access in rural settings. I was quite impressed. Dr. Urvashi said that we don't need doctor, or rather, we don't have doctors everywhere. So what we need is definitely a AI ML kind of intervention, which can help in at least triaging the woman at source. Because today, what is the biggest issue? We all heard the panelists that the initial identification of the woman at risk. If we are able to do that and push that woman into the ecosystem for referral pathway to meet the doctor, consult the doctor, and then doctor can subsequently guide the woman for mammograms or the ultrasound and other tests. I think that is something that we need at the ground level, these AI and ML kind of technologies. Last but not the least, the evolution is also about how we are seeing this private-public partnerships, because those are also giving opportunities for access. For example, there is an introduction to mobile medical units because of that, and because of that we are able to reach lot many women in resource constrained settings with this kind of approach, whether it is a philanthropic capital or combined with some kind of support through NCD. I think at state level it is very much possible, and that has been the evolution, especially in this space. But from the healthcare innovator perspective, we certainly see gaps. The gaps are already being discussed. Just to put it from our perspective, first and the foremost is the skilled workforce, because when we are talking about screening at a population-based level, it is very important to have that kind of ecosystem. And then the affordability, like Dr. Shyam was mentioning about the mammograms across 500 plus districts or 700 plus districts in the country. Now, that's a huge capex cost for institutions and governments. So is the government ready for that kind of cost, or do we need some innovations in terms of lowering the capex, and bringing these AI and ML technologies which can actually triage the initial woman and then bring the woman to the respective hospitals? Because at one point we need district hospitals to be equipped with the infrastructure. On the other side, we need access at the PHC level for population-based screenings so that we can triage and bring women. Last but not the least, there is limited focus on preventive screening. We all understand that, we are aware of this. The numbers are talking about it. Less than 2% women, in fact, less than 1% women takes breast cancer screening test today, which is very, very grave situation. And Dr. Shyam and others were talking about, how this is affecting. One is, we are seeing women. The direct impact is that we are seeing women presenting themselves to the tertiary care or to the clinics at late stages. These numbers are upwards of 75% plus. In some papers I read, it is 90% plus. So it is that kind of grave statistics. Women presenting herself in late stages. So can we change that part? Can we bring in interventions to change that? Certainly, the current mechanisms, which are self-breast examination and clinical breast examinations, are not working because we know the outcomes. The outcomes today is 1% screening and late presentation. So we need to think differently, solve this with some innovative technologies, at least at the population level. Thank you so much. I just take a pause here in case any thoughts from others. I will welcome that.
Right. I also believe that population screening is something which is very widely, not done, and it is what is required today. Here, AI and ML and health tech can help, and especially the self-examination. It's that is not what is helping us, and one person screening is too less. So, Dr. Sham, what are some on-ground challenges you observe in tertiary hospitals related to affordability and access to diagnostics for underprivileged patients?
Right. So that's a very you know different question. The question I was asking is that in a center like Apollo, Max, or Fortis, etc., the underprivileged means a person who is uh, not in the affordable kind of a zone. I mean, is that the question? That so I don't
Yes,
know.
yes.
So how many?
So,
So how many such
demography
are going to be
is a
able to
little bit
reach these
costly.
special? So so I don't know what are we trying to say here, because even in the metro cities where people are educated, who are working, and I mean, they're very quite well aware, because breast cancer has become so very common. I think I'm sure any woman over the age of 35, 40 years has somebody known to her who is either having a friend or a distant relative or a close relative, or in the office, etc., who is suffering from this disease. But the penetration for doing mammography beyond the age of 40 years for all the women in metro cities is even not there. What to talk of, I mean, even doctors, I guess, or who are in medical profession or paramedical profession. Um, I have my doubt they're following the guidelines of 1 to 2 years interval mammography. So I think I don't know how to sort of bridge that gap and encourage women to come out and get the mammography done, so as to, of course, I think in the last few years, for example, in our hospital, all women who get admitted with gynae problems, they don't have a breast problem, but they are admitted for some, gynecologist they are advised to do mammography, whether they are privileged or underprivileged or whatever they are. And we've been picking up screen detected breast cancers, that is, asymptomatic women, they don't have a lump, but then we pick up a centimeter or 5 millimeter lesion, which on evaluation further gets confirmed to be breast cancer. But then, if you see how one can proceed, is that I think in our country at this time, especially in the last 10 years, a large number of cancer centers have emerged. You take the example of Delhi NCR, uh, there are almost 40 centers where we have radiation equipment. And if you talk of the country, I think you have nearly 700 to 800 radiation units. So, the cancer treatment, cancer physicians, cancer surgeons, radiation oncologists, and radiologists, etc., they all tend to revolve around the radiation machine. So, that is one hub where at least all these centers where you have radiation equipment and cancer treatment facilities, one can, have a program that all these centers must have mammography equipment, and a dedication towards promoting awareness about breast cancer, whether it is through NGO or through their institution, or I think, as was said, that there should be some public-private partnership, so as to, the idea is to spread the message that, this disease is becoming more and more common, and you need to go for early testing and early diagnosis. And of course, we also have to encourage primary prevention through education, that you have to take care of your weight, your exercise, your diet, your lifestyle, so that the prevention part is also taken care of. So there are so many issues, which can be done, but then I think that discussions like these help people to firm up their ideas as to how the message can go all across the country, so that, the early detection part or the primary prevention part for breast cancer is given due importance.
Rightly said, sir. With all the cancer care clinics coming up, we can have mammography done in these centers, and we can also educate and address these issues by screening the gynecological patients, those who come to for any other reason to the hospital. So, Dr. Sewanti, can innovations like liquid biopsy or molecular profiling cost will be reduced in long term? And do you still believe that we are long way from making them cost effective for broader population?
So, broader population is a little bit, it is a little tough because liquid biopsies for cancer detection still are quite expensive. Um, I feel they are very nearing prime time for utilization, but it is still quite expensive and not applicable to a population-based screening program. But I feel that way for also any dedicated screening test that requires imaging. For that also, I feel we are really running a tight ship where it's expensive, it's also quite involving, and when we talk about one cancer screening and leave out the other, it's also not inclusive. So you're screening for, you have someone just met me the other day, and they had screened 11,000 women for with mammogram for breast cancer. But I feel that's a lost opportunity. Even as I commend them and congratulate them for having screened these many people for breast cancer, I feel the fact that 11,000 women were there in a room and missed out on other kinds of screening. Really, we have to figure out methods all inclusive methods. And that's where I feel liquid biopsy would be that one answer. Having said that, these are expensive tests. They're in final stages of research. Some of them still need to be validated at Reliance. I'm privy to internal data where the sensitivities are as high as 98%. I've worked with Datar. They also have a very high sensitivity liquid biopsy program. So a lot of these would be directly applicable, but they remain very expensive for population-based screening, and that's where I feel the risk stratification is very, very critical, and that's where um, AI comes in, wherein the early warning signs will help detect the people at higher risk. And those are the people then will have to undergo either dedicated screening tests or liquid biopsies to come up with specific screening answers. Having said that, very basic methods of clinical breast examination are not being practiced in larger part of the nation, and that's where really raising cancer awareness, primary prevention, and recurrent efforts at cancer screening are meaningful. At Reliance, we have current an ongoing program where we are screening 50,000. We are our chairperson, Mrs. Neeta Mukesh Ambani, is committed to screen 50,000 women for cervix and breast cancer, and these are all underprivileged women. My worry, as someone who is leading this effort, is this year we are screening 50,000 women. What happens next year or the year after? So when we talk about public uh, private partnership, we have to talk about longitudinal commitment. We have to figure out a commitment that will stick with us for years to come. We cannot just go out there and provide help this year. I mean, providing help this year, we are very grateful to our chairperson, but we have to have a longitudinal plan of action. And I think that's where a longitudinal commitment with public private partnership is most meaningful, as well as government undertaking for such initiatives is also most critical. And I say lastly that a government undertaking which which changes behavioral patterns is also required. If you screen, I'll give you X, Y, and Z more for Ayushman Bharat. Things like that. I don't know. I think these are things for policymakers to think. I'm just a clinician, but I feel that it's about time that uh, government woke up and took ownership as much as public private partnership. And I always have said this on podium, and I'll say it here also: screening needs to be owned by the people, should be for the people, and we should all come in a revolutionary way to own screening, to get out there and ask each other, have you screened for this year? Thank you.
I think that's a very good message, and I believe that everyone should participate. And screening 50,000 women a year for cervical and breast cancer, that's commendable. So, my next question goes to Ms. Urvashi, since we have been talking about public private partnerships. So, are there current or upcoming government programs or PPP models aimed at subsidizing or scaling breast cancer screening?
Yeah, I mean, like I mentioned, that there's forget subsidized in the health and wellness centers or the Ayushman Arogya Mandirs. It's supposed to happen free, and these centers have been set up or are supposed to be set up at every 5,000 people. There should be one center. So I think ideally, if we have all these centers up and running, we'll be able to cover most of the population. But like I said, it's not about making it free. In the case of breast cancer, it is more about the implementation, doing it systematically, doing it at scale year on year. These are not one-off things, these are not things we can do in campaign mode. And I think, unfortunately, a lot of what we've done in health historically and even till now has been campaign mode. We just take up campaigns, but these are some diseases where you have to keep doing it. It might sound very boring, it might sound like you're just doing the same thing again and again, and so therefore it's not very interesting for politicians because you don't have a new slogan each time. But that's the nature of the beast. You have to just keep at it. So I think that is bringing in that kind of operational discipline, and bringing in that rigor, and bringing in that tracking, that if I've screened a woman this year, where do I have that data, where is it being tracked when she comes back next year, how do I get her back next year. So I think those are all questions that we need to get to from the screening point of view. I think there's a lot that we need to do, even in terms of affordability and financing, on the diagnostics side, on the treatment side, on access to medicines, especially when you have the advanced therapies. Those are still not covered in the public health schemes. So I think on those things, yes, there's huge affordability challenges as well. In screening, theoretically, we shouldn't be having, at least for breast cancer. But that's what I said. That is provided it is happening in all these centers where it is supposed to happen. And that's yet not the case because there's very uneven implementation. So I think that's where we need to focus on the implementation. That's where the public private can really help. That's where the tech can help, if it can make it simpler, if it can make it more easy to scale. We can never have a population screening mechanism in a country like India, where you have like so many people. It can never be if it is something too complex, because we will not ever be able to train people at that kind of level. We will never be able to get equipment if it is very sophisticated. So whatever we do at a mass population level has to be simple, has to be cost effective, and has to be easily scalable. So I think those are the solutions that the private sector can really provide, and in collaboration with the public sector, scale up some of those, so that everybody in the health system. That's what I said, that we have such few specialists, right? And again, very unevenly distributed across the country. So we do need everybody in the health system to have this basic level of awareness, at least, and to be able to use at least some simple tools to even identify somebody who might potentially be in need of further intervention. So I think that is where a lot of our focus has to go. And like I said, that will only happen if we make it a big issue, a political issue. If we say that yes, this is affecting us, it's affecting our families, it's affecting our youth. I think in India, it's very important to make the case that it's not just older people getting cancer. It's much, much younger people as well. The so called demographic dividend that we talk about, people in their 30s to 40s, 50s, even younger, are getting this disease. And so I think that is a case that we need to make very, very strongly, and repeatedly. It's not a one off thing that will achieve anything.
Right. So it has to be scalable, and so that wider and wider population, it can be screened. That is what is required. So, Mr. Vicky, what role do innovative diagnostic tools, especially non-invasive and tech-enabled ones, play in reducing barrier to affordability? Can you share examples of scalable innovation models that support equitable access?
Right. Thank you, Dr. Manisha, for the question. So I think definitely we discussed AI technologies or innovative technologies can bring that intervention, especially when it comes to access. Okay, and and also cost. Like, let me give you examples specific to Niramai. At Niramai, we have developed this AI based medical device called Thermalytics. Now, this algorithm basically detects abnormalities at the early stages. So, what we are doing is we are looking at temperature points which we collect through images and convert every pixel of that thermal image to a temperature point. And then these temperature points are put into our algorithm for analysis, and then algorithm is able to tell where the likely risk. So what it does is, given the portable nature of these innovations, it can reach to remotest places. It can reach to primary health centers. It can reach, in a most affordable way as well. So not only access will increase, but like for example, if I talk about from the Niramai, from our experience perspective, given the conventional, testing, our test comes at a 10% of the cost of the other traditional methods of doing testing, and 30% higher in accuracy, right? So that's the innovation part, and that's the impact new innovations can bring by not only reducing the cost, increasing the access, and also with minuscule of the cost of the traditional methods when it comes to providing access at remotest places. So, from the example standpoint of view, given the portable nature, as I mentioned, it can be deployed in primary health centers. But let's say from the urban area perspective, um, we were talking about still at urban areas, not many women are taking tests. Now, we have been able to provide this at home, so home screening is also possible in urban areas, vis-a-vis, in rural areas, this test can go in primary health centers. So we are trying to solve, a situation where we can provide this to every woman. So that's the whole thought process, keeping it simple, portable, more accessible and affordable, Dr. Manisha.
Right, right. So I think that is what is required: a portable screening tool which can, reach home and screen the wider population. So, Dr. Sham, are you available? Yes,
Yeah,
sir.
I'm here.
So, sir, yes, sir. So, you are a clinician. I would definitely like to hear from you, sir. What is your clinical opinion on portable screening tools, and can they complement traditional mammography, or do you see risk of any false positive or negatives, sir?
So, even the mammography machines are portable. I think there are NGOs and government centers which do have the capability of taking the mammography to smaller areas, rural areas and smaller towns for encouraging screening by mammography. But I think, as has been rightly said, so usually these are, one-time effort, and they are then subsequently not repeated, because this is an ongoing activity for women, which we need to do every 1 or 2 years. Regarding I think we're talking about infrared thermography, which is another tool by which one can pick up hot areas in the breast which could be suspicious of breast cancer. So I mean, sure, I mean, they can certainly be, they're more portable, more easy to perform. But then I mean, again, it has to be done at the mass level, at a regular level. So whatever we do for detecting breast cancers in women, it has to be done on a long term perspective. So it's not out of the realm now, because if you take a cue from cervical cancer, the uterine cervix cancer, I think the WHO has a mandate to eliminate cervical cancer from the world, by the next 10 years or so. So the initiative for eliminating cancers has already begun, and India is part of that. Certain states like Bihar and in Punjab and northeastern states have joined that campaign. So they are focusing on women already, uh, especially on girls under the age of 15 years, to have them vaccinated, and to provide them the testing, which is the pap smear, for women who have symptoms. So the point is that uh, the government and the institutions can join hands focusing on women, because cervical cancer and breast cancer are two common cancers in women. So if we can try and either prevent them or diagnose them early, so you are able to take care of these cancers at an early stage, and one can cure them. But I think a lot of that requires coordination amongst the government, the at the district levels and so on. So I think unless there is a political will, we as clinicians or as NGOs or working in big institutions can keep doing our work. Now, for example, AI has come into the picture, so which can perhaps reduce the requirement for the radiologists, because if the mammography pictures can be sent to a centralized place, the AI can help you giving the diagnosis or the findings of the mammograph, which can be conveyed. So I mean, training people may not be required that much if you use AI. So there has to be a focus on screening mammograms primarily, and maybe these other tools like infrared thermography, etc., in addition to breast self examination and clinical examination. So there has to be a campaign, around this awareness program and the ability to pick up these cancers early through various methods. So unless you have that, it's going to be a one-off effort from one institution, three institutions, four institutions. But yes, people are beginning to realize that breast cancer can be detected early, and I think we need to take appropriate steps through all the agencies available.
Right, sir. So whatever the technology we are following, it has to be, regularly followed, and year on year there should be screening to catch the breast cancer early. So, Dr. Sewanti, what collaborative opportunities do you envision between hospital, research institutions, and tech innovators to close the screening gap more effectively?
There has been a relentless theme across all the panelists and speakers who have joined your meeting today. And that is, it is overwhelming to screen the population. The only way we are going to get ahead of this problem is by risk stratification. And risk stratification by an intervention appears very, very far fetched. Any scan, any blood test, any imaging, any examination that will risk stratify is not going to be able to serve the entire population. I believe that even if we are able to risk stratify based on questionnaire that will help identify early warning signs, questionnaire that is AI backed, it will have to be AI backed to integrate mass level questionnaire based risk stratification. That's when you will be able to identify high risk. And I think all of us will need to come together to design such a questionnaire and make it viable, make it feasible, and make it successful. So I think what Dr. Urvashi also said, she said, we need rigor. We need extreme rigor. We need rigor year after year of identification of the high risk population. So it has to be something very, very simple. Shyam Agarwal sir, I heard the same message. Our friend out here who was talking about AI, also same message. I think we are all identifying that population based screening is extremely difficult. It's a huge challenge. But let us at least not miss the tip of the iceberg that is full of risk. These are patients who have blatantly high risk. And these are not just poor patients. These are not just the patients that you catch and screen in an ambulance or a bus, a screening bus. When you get the vision of screening, you get the vision of a camp. and you are wooing these patients to come and get screened. I am talking about the middle class society, the high risk in people who can afford the screening. Are we screening? Are screening, and society at large is not screening. So high risk identification based on simplistic method with a QR code, where one would be able to answer the question, am I at high risk or am I at low risk? And if I am at high risk, where do I go screen? I think this is oversimplifying matters, but this is my pitch. Thank you.
Right. Right. So questionnaire, that is again a very good idea. I believe that that will help in risk stratification, ma'am. So, Dr. Urvashi, looking ahead, how can policy drive behavioral change around preventive screening, especially in communities with low health screening behavior?
Yeah, I think, we've discussed various policy related issues. I think I agree that we need to have something which, like I said, is easy to implement, and that is always the challenge for us. Policy formulation is the far easier part for most of us, but the policy implementation is where we falter, simply because of our size, our diversity, and then priorities. It's simply not been a priority historically for decades in many, many states in India, I would say. I think apart from the southern states, which have made health and public health a priority, much of the country has always tried to play catch up. When we have a problem, then we try to do something and some piecemeal solutions. What I've been saying is, at the policy level, that we cannot have any piecemeal solutions for cancer. It has to be a very comprehensive approach. It has to be an end to end approach, which starts right from the prevention, the screening, the early detection, right through to your diagnosis, treatment, and even rehabilitation, or ongoing support that a lot of advanced cancer patients need. So I think we're not even there in terms of thinking systematically about cancer. We're always looking for some shortcuts or some low hanging fruit, as we love to use this phrase. But I don't think this is a disease where you can have those. You have to take it up very seriously, and I think we have to all play our part in that. Like I said, if it's an elected representative, they are not going to care unless people in enough numbers care about this issue. So that's what we need to all try and change and work towards. And I think certainly discussions like this help, but we need to, like I said, keep doing it at all levels, in all our circles, in our friends, family, networks, wherever it is, because that's the only way we will be able to have this mass mobilization. Because I think everything is doable at the policy level, but that will is required. Even financing, I don't believe is really ever a roadblock, but it's the will. When we don't have the will, when we don't prioritize it enough, we come up with these excuses that funds are short, or we can't do it, or whatever. But I don't believe that's the case. I believe we can do it, but we need to make it enough of a priority for everybody who is not yet touched by this disease. Because I think what I've also discovered, being a patient myself now, that a lot of people, till the disease comes to your doorstep, it's only then when you kind of wake up. Otherwise, it's like, okay, these are some statistics in the news that I hear or read, but it's not a reality for me. So we have to tell people that if it's not a reality for you today, unfortunately it could be tomorrow, and so you have to wake up to it now. And I think that is the education that we have to do in public health, because that's the only way that policy, elected representatives, politicians are really going to put money behind it, put efforts behind it. And then if we want to pull off something, I certainly believe we can, but we just need that will to be in the right place.
Right, ma'am. So that is the will which is required, and everything falls in place. So my last and concluding question would be to Mr. Vicky. What key enablers are needed to integrate health tech-driven diagnostics into national screening programs?
Right. It's quite a heavy question, Dr. Manisha. So, but thank you so much. We are still figuring out answers to this, but very interesting point made by Dr. Urvashi, and I fully agree. The will is very, very critical, whether it is political will, administration will. I think the role of other key stakeholders are also very important, whether it is the role of clinicians, oncologists, surgeons, and radiologists, um, and also Indian Medical Association as well as other stakeholders who can contribute to this. Uh, so there are no definite kind of steps that we have experienced. What could be the key enablers? But definitely we have observed that initial pilots definitely help for any kind of innovation. Now, these initial pilots can be funded through philanthropic capital, or it could be in PPP mode, or other models that can be. But there is also need to look at how we can ease out the process of CEDESCO registrations or ICMR related whether it is HTA or it is other evaluations to fast track some of the India innovations. It is very important, in terms of the enabling the new innovations. Now, what are the ways to, the national program, or what could be the possible ways to even state level program? We are still figuring that out. We haven't find a kind of a docket saying, okay, if you achieve 1, 2, 3, you are at a state level, and you are at, let's say, PIP level, or let's say you are at national level. But certainly we are just figuring out within the system to look at how we can ease out. But certainly as an innovator, we cannot look at by providing this technology free for a longer period for this kind of continuous evaluations. But it is very important to look at. I would like to end from that perspective. Let's say we just got this information when we were figuring out and trying to speak to different stakeholders. We learned that it's easier to buy, let's say, or import US based FDA approved kind of medical device and integrate into the system much faster as compared to India innovations. So there is a lot to be done. There are a lot of gaps and a lot to be plugged in to support India innovations. To look at innovations coming from India to plug into these, so that we are able to pull these enablers, which can drive not only the growth but also make in India growth as well. So thank you so much, Dr. Manisha, for asking this question. There are a lot of questions here. Actually, I don't have a definite answer, as I said, but thank you for the interesting conversation.
So, on that note, I thank you all for being part of this important conversation. Let's carry the momentum forward to ensure that every woman, no matter where she lives, has access to timely, effective, and compassionate breast cancer care. Thank you very much.
Thank you.
Thank you, everyone. Thank you, everyone.
Thank you.